Hello, everyone. Welcome. My name is Dr. Elahe Behrooz, and I am one of the prosthodontists working at Prosthodontic Associates. I'm also involved in teaching at the University of Toronto and the Mount Sinai Hospital here in Toronto. And it's with great pride that I say that I have been to your country, Uganda, 3 times. And as of this point, I really do miss being there, and I do wish that our next symposium is going to be an in-person one so that we get a chance to all get together again. Do miss you guys and your country, and I'm very much looking forward to coming back. So today I'm going to be talking about one of the topics that in dentistry we all find that sometimes answering some questions might be a challenge. It's basically what I would like to call a dental dilemma, and that is the restoration of endodontically treated teeth, or a restoration of teeth that have had root canals done on them. So before getting into the topic of restoration of endodontically treated teeth and what do we actually do to restore endodontically treated teeth, I just wanted to take a couple of minutes to talk a little bit about the concept of restorability of the single tooth. So the most important question to ask ourselves before we commit to longer or more involved treatment or committing to a root canal treatment on a tooth is to ask this question: is this tooth restorable or not? And so to answer this question, there are a couple of concepts that I want to just highlight. So I want to talk about a little bit about the prosthodontic prognosis of heavily restored or compromised teeth. So I just want to do a quick reminder that our key consideration in determining whether teeth are restorable or not is the amount of remaining sound coronal tooth structure. So this seems to be the most important factor which influences our decision making when it comes to what is the prosthodontic prognosis of a single tooth. It also determines what kind of a retention and resistance form our direct and indirect restorations or fillings and crowns are going to have. Key here is that every restoration or filling on the tooth needs to be removed for us to assess this particular aspect appropriately. And also the amount that is considered to be adequate depends on your treatment plan. What are you going to be treating this tooth with? Are you just going to do a filling on this tooth, or are you going to do a crown on this tooth? So the amount that is considered to be adequate regarding the amount of coronal tooth structure depends on what your treatment plan is. Here I have a couple of secondary factors. So considering the primary factor is the amount of coronal tooth structure, secondary factors are how much ferrule do I have? Do I have any fracture lines on the tooth? Can I predictably achieve coronal and marginal seal with this tooth? What is the occlusal scheme on this tooth, or what are the occlusal forces on this tooth? And what are my aesthetic demands regarding this tooth? So this brings up the concept of ferrule, which is another very important dental term. So what do we mean by ferrule? Ferrule is the amount of sound dentin or healthy dentin that surrounds or extends coronal to the margin of your crown preparation circumferentially. So it's that part of intact tooth structure that your crown hugs or your crown covers. Generally speaking, the literature suggests about 1.5 millimeters to 2 millimeters of ferrule height to be the minimum that we accept. And when we have a good ferrule on a tooth, this lowers the impact of whatever other treatment we're doing, whether we're doing a post, a core, lutein agents, what is the final restoration on the tooth. So all of this basically depends on the amount of ferrule we have. And when we don't have ferrule, we don't have a good prognosis. So generally speaking, ferrule is a very, very important thing to check before we commit to more involved treatment. Generally speaking, when we don't have ferrule, we have fractures or failures such as the ones that you see in these photos. So generally, minimum of a millimeter height, depending on the papers you look at, 1.5 to 2 millimeters or a millimeter of height is what is considered to be adequate. Regarding the width or the thickness of the dentin wall, which is in the ferrule, the minimum height generally is more researched. We have more concrete numbers on the height than the width, but the width seems to only be meaningful when we have adequate height, and the height seems to only be meaningful when we have adequate width. So basically, if we're looking at numbers, we should have at least a millimeter of height and at least a millimeter of width, ideally about 1.5 to 2 millimeters of height. Ideally, again, we want to have circumferential ferrule, but if we have to pick and choose, as long as we have buccal and lingual walls, it's actually more important than the mesial and distal walls. Reason being, the teeth are generally protected by the contacts that they have on the mesial and the distal aspects. But the buccal and the lingual, the teeth are generally not protected. Another factor that plays an important role is what type of tooth we're looking at and how much occlusal forces or lateral loads are we anticipating to have on the tooth that we're treatment planning. So now that we've talked a little bit about the restoration or the restorability of the single tooth, let's get to the meat of the presentation, which is restoration of root canal treated teeth or endodontically treated teeth. So whenever you are considering to restore a root canal treated teeth, the number one factor is that you have to evaluate the quality of the root canal. So we have to see if there is a good apical seal. The tooth should be asymptomatic, so there shouldn't be any sensitivity to percussion. There shouldn't be any discharge, any pus, any exudate. There shouldn't be any fistula associated with the tooth. There should be no apical palpation tenderness or sensitivity. So generally speaking, there shouldn't be any active infection going on. So no signs or symptoms of infection should be detected. Once you clarify or confirm that the quality of your root canal treatment is ideal and that, or acceptable at least, and then you also confirm that there is no active infection going on, then we can get into the restoration of endodontically treated teeth, which in and of itself is actually a very controversial topic. So depending on what papers you look at, there unfortunately isn't any standardized measure or clinical guideline which tells you exactly where to put a post, a core, what type of post to use, what type of full coverage restoration to use. By FCR, I mean full coverage restoration or crowns, and what type of crowns should we be using on these teeth. Generally speaking, though, we know that these teeth, because of the loss of tooth structure, which is secondary to the access cavity preparation and also to the actual process of root canal treatment, these teeth have less fracture resistance. So generally, some sort of adjunctive therapy is usually recommended. They do tend to have the same modulus of elasticity as non-root canal treated teeth. So that myth of teeth being dehydrated and more susceptible to fracture is actually a myth, but we do have an issue with retention of restorations on these teeth. So how can we choose what type of restoration do we do on these teeth? It depends what tooth we're dealing with. Is it an anterior tooth or is it a posterior tooth? And if it is in a strategic location like in a canine site. It also depends on what we said was the most important factor in determining the prognosis of endodontically treated teeth, which is the amount of remaining coronal tooth structure. And also it depends on your overall treatment plan. So what is a post? We all know what a post is, but what does it do? Basically, what it does is it retains the core, which ideally should be bonding to the dentin or the coronal dentin. So the primary purpose of having a post is to retain a core. When we don't have enough coronal tooth structure to provide to the tooth with a core for a crown to go on top, that's when a post comes into play. It also helps with the fracture resistance of teeth. And generally, when we're doing posts in root canal treated teeth, we should be choosing the biggest and the largest and the straightest canal. So usually this is, let's say, for example, in maxillary molars, typically the palatal canal is a good canal to go to. And generally, the pulp chamber, or the area that has been used for access cavity preparation, can also be used for retention of the core. Generally, what you want to achieve is to have an adequate adhesive bonding of whatever post system you're using to your canal as well. So that's very important. So what else do posts do? Or how do we know if we need a post or not? Generally, what they provide us is they restore missing tooth structure to so a full coverage restoration can be placed after completion of root canal treatment. So again, when you don't have enough coronal tooth structure, but you want to place a full coverage restoration of a crown on top, this is where a post retains the core. When the tooth is going to carry occlusal loads, or when you know that there are going to be biting forces on the tooth, then you may need a post. It also helps to create a solid structure from an empty structure in the radicular or the root canal space. And it also builds up a functional tooth support unit when there's significant loss of tooth structure. So these are basically the most important purposes that posts can have for us with restoration of endodontically treated teeth. Now, when we're looking at posts and cores, we also should be looking at ferrule walls. And when we're determining if this tooth is a good tooth or if it's not a good tooth, we want to know what ferrule walls in which teeth are more important. So I want to give you a little bit of a take-home message here. Generally speaking, in the maxillary anterior teeth, let's say, because the forces of occlusion are non-axial on these teeth, the palatal wall seems to be the most important wall. So when we're missing the palatal wall in the anterior maxillary teeth, we are into a situation which is very prone to fracture. By FX, I mean fracture. If generally in anterior maxillary teeth, we've only done a very small endo axis and the coronal tooth structure is largely untouched and we have good occlusal force directions, then maybe just the filling would be enough for these teeth. If we have about a, let's say, a height of about 3 millimeters and a width of 1 millimeter of ferrule, a little bit of ferrule, then we can just have a core and no post. So basically composite core, and then maybe with or without a crown will be enough for you. But if you have about height of 1 millimeter to 3 millimeters and a width of about 1 millimeter and a questionable ferrule of about maybe 50%, then you actually may need a post. Anything below that, I would very seriously consider placing a post in the tooth. With posterior teeth, though, mostly these teeth are axially loaded, meaning the forces of occlusion are directed vertically on these teeth. So that's a better loading than the anterior segment. So generally speaking, for premolars, in the mandible, the buccal wall and group function, in the maxilla, the palatal wall and group function, these are the very important walls. But if you look at things in the grand scheme of things, Generally speaking, posts are well indicated in the posterior teeth. So as more walls are missing, there is more need for post and core reconstructions. And even with 3 remaining walls in posterior teeth, which are under heavy occlusal loads, a post may be beneficial. So again, as I mentioned with molars, because the forces are axially directed, if you generally have just an endodontic access, you may not need a post. If you have a large amount of tooth structure removed, like the mesial wall, the distal wall, then a post may be required. If you don't have any wall remaining, then basically if you put a post in, you're actually adding to the prognosis of the tooth or adding to the longevity of the tooth. So what you're doing here is a post the tooth may fracture anyways, but if it has a post, then the fracture may actually be a restorable fracture, whereas it may be a non-restorable fracture if we don't have a post. So if I can give you a take-home message in a nutshell, in the posterior tooth, you do want to have a post in, unless you have a very, very conservative access channel, just an access cavity preparation. So now the question is, do we do a crown or do we not do a crown? So this is an important slide. I always look at this when I'm treatment planning my patients. In my mind, I basically look at these indications and contraindications. If you're looking at anterior teeth, generally, if a crown is not required, a post is also not indicated. So we first have to assess if we have to do a crown for the tooth. If a crown is required, meaning interproximal walls are gone or a lot of tooth structure is missing, then a post is usually indicated as well. So basically in the front teeth, crown and post kind of go hand in hand. If you don't know if you need a post or not, if you don't know if you have adequate coronal tooth structure or not, complete your crown prep first, assess how much tooth structure you have remaining, and then you can decide if you want to do a post or not. For posterior teeth, usually we want to go for a crown or a full coverage restoration when we have a root canal. So molars always, premolars, questionable, always in the maxilla. Mandibular premolars though, because generally the access cavity preparations can be very, very conservative because of the location of the canals. We may not actually need crowns. So generally speaking, for posterior teeth, we mostly need crowns. Posts we may or may not need. For anterior teeth, they kind of go hand in hand. So I think that this table summarizes things. So let's say for an anterior tooth, if the remaining walls are about 3, do we need a post? Probably not. For premolars, probably not. For molars, no. If we have only 2 walls remaining, for anteriors and premolars, we probably need a post, but for molars, we don't. If we only have 1 wall remaining for an anterior teeth, then we do need a post. And basically, if you have 1 wall, any tooth would benefit from a post. So this is just another way to summarize our findings. Now, what are the prerequisites for post and core treatment? If you're doing a post, you have to have adequate ferrule. The post retains the core. It does not replace your ferrule. So you have to have adequate ferrule for you to be able to put a post inside a tooth. And then you also do have to have enough coronal tooth structure remaining to support the post and core, and a good, well-executed root canal treatment. What if we don't have ferrule? Then sometimes we can just move our crown margins a little below the gum line to get a little more tooth structure with respecting the biological width. Sometimes we can just do some gingivectomy, remove some soft tissue or some gum tissue, and then we can expose more tooth structure. So that gives us a little more ferrule. Sometimes we need CCL, or clinical crown lengthening. So that's a surgical procedure. It removes bone and soft tissue around teeth, so exposes more tooth structure to provide us with ferrule. With this, we have to make sure that our C to R, or crown to root ratio, is still good after the procedure. And sometimes you can just do orthodontic extrusion. So with orthodontic forces, extruding the teeth outside of their bony sockets so that you get a little more ferrule. So these are the four classic methods of obtaining ferrule. Now, what is an ideal post? The ideal post allows you to have minimum removal of tooth structure. It doesn't corrode in tooth structure. It's a nice looking post, so it's aesthetic. It can be adjusted easily, and it is easily removable from the tooth structure. If it fails, so you can remove it. It should be radiopaque so that you can see it visibly in radiographic examination. Its modulus of elasticity should be similar to tooth structure, so it doesn't contribute to fracture of teeth, and it should be retentive in the canal and provide retention for the core. Can we find any post and core system which has all of these characteristics? Absolutely not. But if some systems have most of these characteristics incorporated in them, then they are probably good systems. Now, there are different types of posts. They can be active, they can be passive, or parallel or tapered. They can be prefabricated in the market, or they can be custom made for that canal for the patient. And in terms of materials, there are also very many different types. So an active post generally is what you see in the upper photo. It's threaded and it engages in the canal walls. A passive post does not engage the canal walls. It just is retained by the luting agent or the cement that you're using. Parallel posts are very retentive. They engage canal walls. They are less stress inducing inside the canal because they don't have that wedging effect. But you have to remove more tooth structure to put in these posts because the end of the post is parallel. So end of the post is actually pretty large as opposed to a tapered post, which requires less dentinal removal. We also have prefabricated posts or custom fabricated posts. Custom made posts have the advantage of being specifically made for that patient, for that canal, so they conform to canal shape. They are lab fabricated, so they're more expensive, but they are very, very conservative. What I mean is they require the least amount of tooth structure removal because we make the post fit the canal and not the canal fit the post. So these are just some general photos of the different types of posts in the market. You can have tapered smooth-sided posts, tapered posts which are serrated, tapered posts which are threaded, so actively engaging canals. So these can actually cause fractures and complications sometimes. Parallel posts also can be smooth-sided or serrated or threaded. In general, when we use threaded designs, such as some of the ones that you'd see here, like C, E, and F, these engage the canal, so they're a little more aggressive. And basically, when we're using tapered posts, because of the wedging effect, they can also be a little more dangerous in terms of fracturing and opening up the canal space. In terms of the materials that the posts are made out of, they can be out of a metal alloy, so ideally a gold alloy. These are cast, very similar to PFM crowns or porcelain-fused to metal crowns. So these are made in the lab. They're done by investing in casting. They can be base metal or titanium or stainless steel. But we also have tooth-colored posts these days, such as fiber posts, zirconia posts, and ceramic posts. And these are beautiful posts. So this just to give you an idea that mostly the parallel-sided posts are made of certain types of metals. Serrated posts, for example, stainless steel, titanium and Nobel alloys. Tapered posts are also made of different alloys and titanium alloys. So this is just for your information to know that the prefabricated posts that are out there in the market generally are made by different metal compositions. Now, what I really like about custom-made cast posts is, as I said, they are made to fit the canal. The canal is not enlarged to fit them. So these are perfect for canals which have non-circular cross sections or extreme tapers, or basically when we have a situation where if we enlarge the canal space to conform to the post, we may lead to over-reduction or perforation. These require minimum preparation, so they're very conservative. But you have to keep an eye on the danger zones. For example, in the mandibular molars, the root cavities on the distal wall of the mesial root and the mesial wall of the distal root are where you want to make sure that you're very conservative with dentin removal. For the maxillary molars, also the curvature of the mesiobuccal root, for example, which usually curves distally, you certainly want to make sure you don't over-reduce in those areas. So the good thing about these cast posts and cores is that they are very conservative. They have one structure, so the post and the core are made from one material. So we don't have a separate post and a separate core and them being bonded together. So we have less interfaces. So we have just one monolithic or single material made structure, single interface, and because gold can be bondable, the basically bond between these posts and teeth can be pretty amazing. When we're considering whether we should be doing cast or prefabricated posts, we have to consider the following factors. Number of interfaces, which is much less with cast, so that's better. But we do need lap support with cast posts and cores, so keep an eye on that. We do need to make sure that we have some lap support. It is more technique sensitive and more difficult to do cast posts and cores, so you need to be comfortable with doing them. They're more costly, but they come with the advantage of being bondable to tooth structure. So I just wanted to bring this to your attention. Which design would you choose between these two designs? And if this was done in person, I would have loved to hear what you had to say. Unfortunately, the answer here is none of them are good because none of them have ferrule here. But generally, my preference is cast posts and cores, given the tooth has adequate ferrule. I just wanted to bring up this new topic as well for you guys. There's also the concept of zirconia posts. They're very nice. They're an aesthetic alternative to metal posts. We don't have a really long-term information on these type of posts and cores, but generally they can be used in anterior teeth. It is a ceramic material and it looks really nice. And generally they have proven to be very successful with survival rates of about more than 80% in 10 years. So basically what you do is very interesting. You scan the root canal and then you have either a model, basically either a wax up of the post and core system that you then scan and mill the zirconia out of, or you can even have a scan body that you place inside the root canal, inside the post space, and you can scan things, and it's very interesting how these are made. So basically it's a completely digital process, and these zirconia posts are milled out of zirconia. They generally have very nice fit inside the canal. Zirconia is a very strong material and therefore it's very durable. However, the bondability of this material to tooth structure may be a little questionable. So this is just an impression that is being scanned. You can do a scan inside the patient's mouth, or you can actually scan an impression of the patient, and then the computer basically mills the post for you. So these are very interesting digital ways in which we can fabricate post and core systems as well. I just thought I'd show it to you, and they're very, very aesthetic. You can use them in the front part of the mouth without a metal show through. Other posts that can be used are fiber posts. So these were also introduced back in the 1990s. They're also very nice. They save your time, they eliminate your lab fee, and there's no corrosion with these posts. And there is easier retrievability with these posts than generally the cast posts and cores. So these are generally glass fibers, parallel and distributed equally over the surface. And basically, because they have a modulus of elasticity, which is very similar to dentin, they're not very prone to fracture. Good thing is they are radio opaque, and the only issue with these posts is that they sometimes de-cement from the crown, from the radicular space. So these are some examples of the fiber posts, and they come with their own drilling system. So basically you drill and you fit in the posts. And just a little bit of information regarding cores. So what does a core do? A core basically goes on top of a post to build the tooth to ideal anatomical form prior to crown prep. It simplifies subsequent crown preparations, and the material of the core basically depends on how much coronal tooth structure you have, what is your overall treatment plan, what are your aesthetic expectations, and what is your preference as an operator. But generally you can use either amalgam or resin modified glass ionomer, composite resin, or the cast gold, which comes with its own post. So with that being said, I hope that these couple of slides in the past 30 minutes has given you a little bit of information regarding how to treat your endodonically treated teeth. And it's truly been a pleasure to be part of this symposium, and I look forward to seeing each and every one of you in person, hopefully very soon.